Good evening, students. Welcome to you from Sri Rama Hospital, Jagaipet. In the previous class, we learned some of the arterial diseases, and later we learned about gangrene. And we are studying about some of the types of gangrene, special types of gangrene. Now today, let us study about a special type of gangrene called frostbite. This is extremities exposure to extreme cold accompanied by wind and high altitude. So when the persons are exposed to extreme cold, where there is a lot of wind and high altitude, so this type of gangrene can occur to the toes and fingers. The changes depend upon the environmental temperature. Below 10 degrees centigrade, vasoconstriction of peripheral blood vessels take place. This causes slowing of the blood flow. Hemoconcentration and altered RBC metabolism occur because of the slowness of the blood. This produces increased viscosity, and this causes capillary sludging and thrombosis of the arteries. This causes gangrene. Clinical features: pain, swelling, and pallor initially, bleps with swelling and later gangrene. Diagnosis: Doppler's probe test to assess the patency of the vessels. Prophylaxis: usage of boots and gloves in cold climates. Avoidance of tight boots and straps of boots in cold environments. Enforced exercise in cold climate. When the person walks or jogs, so by jogging, there will be increased blood flow to the calf muscles and to the peripheral extremities. Treatment: the whole body should be warmed gently before the extremity is warm. Some people, what they do is, this is because of cold, the injury is because of cold, they immediately warm the feet and fingers. That should not be done. What will happen? Because it is cold injury, you warm it. What is the harm? Why it is said that should not be warm? Why the whole body should be warmed before the extremity is warm? It is not like that. By warming, the basal metabolism increases. So the basal metabolism increases, but the vessels will take some time to dilate because the vessels will be in deeper layers of the tissues. So first the tissues get warm. So they need, once the basal metabolism increases, they need more oxygen. But the constricted vessels cannot supply it. But instead of that, if you do whole body warming, that means you warm the other parts of the body, then what will happen? The blood becomes warmer. The warm blood will flow through the leg veins or leg arteries. So that will cause them to dilate. That is why first the central part of the body has to be warmed, then the peripheries has to be warmed. Analysis: sympathetic blockade with paravertebral or satellite stellate ganglion blockade. Hyperbaric oxygen, injection of heparin and low molecular weight dextran, antibiotics, then conservative amputation of the gangrenous spots. If there is gangrene, means it is irreversible death. So if it is there, then the patient needs amputation. That is conservative. Conservative amputation means only the part that is affected, that became gangrenous, has to be removed. That is called conservative amputation. Then trench foot. Exposure of extremities to cold, moist, or damp environment with tight boots or clothing, as in mariners. Clinical features: numbness of the feet followed by pain. Skin is mottled with blisters. Later, moist gangrene develops. Treatment is same as the frostbite. Arterial injection due to arterial occlusion due to intra-arterial injections. Certain drugs, if accidentally injected into the arteries, cause severe arterial damage with thrombosis. These drugs being thiopentone sodium. What for it is used? Thiopentone sodium. Thiopentone sodium. What for it is used? It is an short-acting induction agent. It induces anesthesia. Okay. Quinine, cytotoxic drugs, then sclerosants and hypertonic saline. Long-acting barbiturates, especially drug abusers. Cause: high division of brachial artery with one of its branches, usually the ulnar artery, passing superficially, may be mistaken for a vein in the cubital fossa, and accidental injection may be given into that artery. This is the brachial artery. Usually it divides into radial and ulnar opposite the radial tuberosity or neck of the radius. But sometimes what happens is it divides the arm itself, the lower part of the arm, into radial and ulnar. In that case, the ulnar artery runs superficially. Because there is already one radial artery, there is one more artery is there, two vessels will be there in the cubital fossa with pulsations. People will mistake one for the vein and they may inject the drug into the artery, then causing the damage. That is why whenever you see the anesthetist will inject thiopentone sodium into the dorsum of the hand. They will not inject at the cubital fossa for the same reason, because sometimes there may be anomalous high division of brachial artery with ulnar artery running superficially, which may be accidentally mistaken for the vein. Immediate severe burning pain and blanching of the hand. So once the injection is being given, the patient complains of severe burning pain and the whole hand blanches. In severe arterial injury, gangrene also develops. In less severe cases, Volkmann's contracture develops. If there is partial occlusion, then patients will develop Volkmann's contracture. Otherwise, severe injury where the thrombosis occurs in the arteries, the patient will get gangrene. Prevention: palpating the vessel for pulsations before injection. Aspiration of bright red pulsatile blood or any complaint of pain in the limb while intravenous injection should make the physician alerted. To avoid antecubital fossa for thiopentone injection. When the accident is suspected, the needle is left in situ and intra-arterial injection of heparin and piperacillin is given. Then IV low molecular dextran is administered. Systemic anticoagulant therapy is started. Stellate ganglion block is given to reduce the arterial spasm. Amputation if gangrene develops. So that is about the gangrene. Now, the other arterial disease is the aneurysm. Okay, Volkmann's ischemic contracture. Whenever there is partial occlusion to the blood vessels, then the capillaries supplying the muscles, they undergo thrombosis because of reduced flow. So that causes necrosis of the muscle fibers. But the skin, subcutaneous tissues and fascia, they are viable. Only the muscle fibers are necrosed. So then what happens? The muscle fibers which are necrosed are replaced by fibrous tissue. In a period of 3 weeks' time, this can happen. So usually this happens after reduction of the fractures with POP application. Whenever there is fracture, there will be a lot of bleeding at the fracture site. And because of the injury, there will be edema of the muscles. Now you apply POP casing around the forearm. If you apply the casing tightly, then it will cause a tight occlusion of the muscles here. So because of this tight occlusion, the muscles become ischemic and they necrose. They will be replaced by fibrous tissue. So whenever fibrosis is there in the muscles, they contract. So when they contract, what will happen? Normally the muscles have the elasticity. So you can move your fingers backwards or you can move your fingers forwards. But when the muscles are constricted or contracted because of fibrosis, so the flexor compartment is mostly affected. So the flexor tendons are pulled. So the fingers will be in this flexion attitude. The wrist will go into dorsiflexion. The metacarpophalangeal joints and IP joints, they will be in flexion position. If you want to extend it, it is not possible. But you will be able to extend the fingers by flexing the wrist. So you can flex the wrist like this, then there will be some gaining of length of the tendons. So you will be able to do like this. So this is the Volkmann's ischemic contracture. So that is why whenever you apply POP casing for a fracture reduction, after fracture reduction, you must check for the muscle pain. How do you check for muscle pain? By just extending the fingers. If you extend the fingers, the patient has a lot of pain. That means the muscles are stiff and they are tender. That indicates that there is ischemia. Then you must check for the pulp and nail bed for blanching. So just press it and leave it. Normally there will be blanching and return of pink color. That will be delayed. That indicates there is some vascular insufficiency. Then immediately you must cut open the POP casing. In established cases, you must always go for some tendon transfer or tendon lengthening operations. Okay, now let's go to the other topic, that is the aneurysm. Dilatation of localized segments of arterial system when there is more than 50% increase in the diameter of the vessel. When there is less than 50% of dilatation, it is called as ectatic. That means simply it's called as arterial dilatation. If it is more than 50% increase in the diameter of the vessel, then you call it as the aneurysm. Of course, this is the recent definition of the aneurysm. The old definition was saccular dilatation of the vessel with which communicates with the vessel lumen is called the aneurysm. Classification: they are classified into true and false. The true aneurysms being fusiform, saccular, dissecting. False means it contains single layer of fibrous tissue as wall of the sac. Example being post-traumatic pulsating hematoma. Already I told you, whenever there is a partial rupture of the vessel wall, the blood will leak, form a hematoma, and the hematoma gets organized. It gets fibrosis all around and a cavity inside which communicates with the blood vessel and it pulsates. So this is called a pulsating hematoma. Myocardic aneurysms caused by bacterial infection of the vessel wall leading to thinning of the vessel wall and dilatation. Then arteriovenous fistula, congenital and acquired. Causes of aneurysm: congenital, example berry aneurysm and the circle of Willis, splenic, renal and celiac arteries. That means very small, just like berries, there will be aneurysms on these vessels. Then organic causes: atherosclerosis. That means atherosclerosis is a degeneration of the vasomedia and vasointima. During the degeneration, the smooth muscle tissue is replaced by the fat deposits. So during this time, because the media is replaced by fat tissue, it becomes weak. So it can undergo dilatation. Then syphilis. Syphilis causes endarteritis of the vasorum, causing necrosis of the vasomedia, producing development of fibrosis, and it causes dilatation. Then mycotic aneurysm due to subacute bacterial endocarditis. Then traumatic aneurysms, collagen diseases like Marfan syndrome. Of course, the commonest cause of aneurysm is due to atherosclerosis. Sites of occurrence: major arteries, aorta, popliteal, femoral. So these are the commonly involved. The others being subclavian and carotid. Small arteries: cerebral, splenic, mesenteric, and renal. Splenic artery is the second most common site of abdominal aneurysm. The first common site of abdominal aneurysm is in the aorta. The second common site is the splenic artery. Abdominal aneurysm is the most frequent site of aneurysm. Popliteal aneurysm is the next frequent site, but the commonest peripheral aneurysm. So when you take the peripheral aneurysms into consideration, then the popliteal aneurysm is the commonest one. Effects of aneurysm. So whenever there is dilatation of the blood artery, what will happen? So the changes can be intrinsic and extrinsic. What are the intrinsic changes? Thrombosis, embolism, rupture. Then extrinsic effects of the aneurysm being due to pressure on the neighboring structures like the veins, the nerves, the bones, joints, viscera, trachea, esophagus, etc. So neighboring structures may be put to pressure by this aneurysmal sac. Clinical features: a pulse-style swelling. The swelling will be in the course of an artery. There will be expansile pulsations. I hope all of you know how to demonstrate expansile pulsations. How you demonstrate expansile pulsations? How you demonstrate expansile pulsations? You must, swelling will be there. So over the swelling, what you should do is you would keep your two fingers over the swelling. So keep your two fingers over the swelling and observe these fingers, whether they are lifted up and separated, or they are just lifted up. If the fingers are just being lifted like this, it is transmitted pulsation. If the fingers are being lifted and separated, then it is expansile pulsation. So this is called the two-finger pulsation test. In case of aortic aneurysm, the pulsation doesn't disappear on knee elbow position. So we learnt about this when we were studying about the pseudopancreatic cyst. So this is how you do the test. If it is an aneurysm, the fingers are lifted up as well as they are separated apart. If it is a transmitted pulsation, the fingers are just being lifted up. So when a pulsatile swelling is there, there will be expansile pulsation. Next is proximal pressure on the artery diminishes the size. If aneurysm is clotted, then it will not reduce in size. On release of pressure, the swelling reappears with increasing size and each pulse beat. The swelling is compressible if mural thrombus is not present. You can just compress it. Next feature is the presence of bruit and thrill over the swelling. Pressure symptoms and pressure signs like edema, paresthesia, dysphagia or stridor when it is causing pressure over the trachea or the esophagus. Then chronic or acute vascular occlusion due to thrombosis or embolism. Because intramurally, there can be development of thrombosis. From the thrombus, a small embolus can dislodge and can cause acute vascular occlusion. If it ruptures, then there will be profuse hemorrhage followed by shock. Differential diagnosis, you have to always differentiate an aneurysmal swelling from swelling under an artery. For example, cervical rib with subclavian artery coursing over the rib. So what will happen? Because rib is there, subclavian artery is coursing over it. So you will, when you feel the base of the neck, you will feel a mass here. And over the mass, you will see the pulsations. So when pulsations are there and a mass is there, you are likely to diagnose it as a aneurysm. Then presence of swelling over an artery, like pseudopancreatic cyst over the abdominal aorta, then also you will mistake it for aneurysm. Highly vascular tumors, like bone secondaries from renal carcinoma, follicular adenocarcinoma, thyroid, osteoclastoma, and osteogenic sarcoma. These can be having highly vascularity. So when they have high vascularity, there will be the pulsations. The long tortuous atherosclerotic artery. Sometimes a deep-seated abscess. Patients will have pain. The pain will be throbbing in nature. That means it will be just like pulsations. The pain will be there. So when you ask the patient, the patient will say it is pulsating, because the pain will be like that. Investigation, duplex angiography, arteriography, ultrasound scan of the abdomen for abdominal aortic aneurysm, MRI angiogram. Treatment, indications for surgery, symptomatic aneurysm, that means aneurysms which manifest with the symptoms like thrombosis, embolism, pressure effects, pain. Asymptomatic aneurysm, which are discovered incidentally on ultrasound examination, of more than 5 centimeters in diameter, so they should be operated because there is an incidence of high incidence of rupture in these cases. The type of surgery depends upon the vessel involved, the availability of the collateral circulation, and distal patency. The treatment can be proximal and distal ligation, followed by excision of aneurysm sac in peripheral small vessels like radial artery, ulnar artery, posterior tibial artery. So what you can do is you can just proximally and distally you can ligate it and excise it, because there is profuse collateral supply. If collateral supply is not there, then you must do resection followed by anastomosis like this. You can put a reverse saphenous vein graft here. Then resection and reconstruction of the vessels. For large vessels with a prosthesis, for medium-sized vessels with an autologous vein graft. The graft may be laid inside the aneurysmal sac, which is not excised but isolated from the artery proximally and distally. Example, abdominal aortic aneurysm. For example, abdominal aortic aneurysm is there. It usually occurs below the renal arteries. Now, how to reconstruct it? How to resect it? Around the aneurysmal sac, there will be a lot of adhesions. And it is adherent to the inferior vena cava. It is adherent to the ureters, and it is adherent to the mesenteric vessels. So it will be difficult to separate all those structures, and sometimes there may be injury to those structures also while you are removing. So what you do is you apply vascular occlusion clamps above and below the aneurysmal sac. Then you make an incision over the aneurysmal sac and open it. So you can see the opened up aneurysmal sac. You can see small vessels. These are the mouths of the small branches, lumbar arteries, and other small vessels that are going from the abdominal aorta to the surrounding structures. So these mouths are closed by suturing. Now you take a prosthesis and you implant it inside. Cut the artery here and suture it here, and cut the artery here and suture it to the artery. That means the graft is laid inside the aorta. Then what you do? You put back the flaps which were opened up. So this is the aortic wall. So the wall of the aorta is again replaced over the graft and sutured back. So this is called the inlay graft repair of the aneurysmal sac. Inlay, you are keeping it inside. That is called the inlay graft repair. Sometimes what you can do is you can place a graft outside like this. This is aneurysmal sac. You ligate it, don't remove it, but place a graft outside. Aneurysmography, it is done for peripheral saccular aneurysm. The aneurysmal sac is excised and the defect in the arterial wall is repaired. For example, a saccular aneurysm like this is there. So the whole artery is not dilated here. Only one side of the vessel is dilated. Then in that case, what you do is you just excise that sac and then you repair it. Let us see some of the salient points about some common aneurysms. Abdominal aortic aneurysm. Incidence 2% of the population, 95% occur below the renal arteries. Clinical features, most are asymptomatic and discovered incidentally on abdominal examination or on ultrasound scan. There will be discomfort in the abdomen and back because the aortic aneurysm will be causing pulsations over the bodies of the vertebra, lumbar vertebra. And there will be pressure erosion of the lumbar vertebra. So this causes pain in the back. Pressure symptoms, you talk pressure on the ureters, inferior vena cava, femoral nerve get compressed. Whenever there is sudden expansion or rupture, there will be severe back pain. So if rupture occurs, the abdominal aortic aneurysm can rupture. Already I told you, if it is more than 5 centimeters in diameter, it is for threatened rupture. So if it ruptures, what will happen? Rupture is suspected in a patient with abdominal aortic aneurysm with triad of severe abdominal or back pain, hypotension, and a pulsatile abdominal mass. So in a patient who had already a history of abdominal aortic aneurysm, if that fellow comes to you with severe abdominal pain or back pain, hypotension, and pulsating mass in the abdomen, you must immediately suspect rupture. If it is a rupture from the anterior side of the abdominal aorta, there will be profuse bleeding into the peritoneal cavity, and before patient reaches the hospital, he may die. If the rupture is there from the posterior side of the aorta, because it will be in contact with the retroperitoneal tissues. So because of the pressure, there will be some oozing of blood or leaking of blood, but there is no such catastrophic loss of blood. So patient can reach the hospital and there will be time for you to do surgery immediately. Investigations, CT scan, then management, indications for surgical management, asymptomatic if more than 55 millimeters in diameter, and also in symptomatic cases. You can do open aneurysm repair, that means the inlay graft, or you can go for endovascular aneurysm repair with endovascular processes. So there is a endovascular process is there. What you do is, for abdominal aortic aneurysm, you prepare both the thighs, open the thigh in the upper part, expose the femoral artery. So through the femoral artery, you pass a guide wire into the aneurysmal sac. Then, over the guide wire, you pass a balloon catheter. Then, over the balloon catheter, you introduce a prosthetic stent and see that the stent is placed in the aneurysmal sac under fluoroscopy control. So this is how you place the stent in the abdominal aorta. And the stent, once it is placed there, you will pass the balloon catheter and then inflate it so that the process will be there adherent to the abdominal aorta. It will have some barbs outside. So the barbs will cause the penetration into the aortic wall and they keep the stent in place without getting displaced. Popliteal aneurysm is commonest of all peripheral aneurysms. 50% are bilateral. 33% are associated with abdominal aortic aneurysm. Clinical features: peripheral ischemia, pulsatile swelling in the popliteal fossa. Management: symptomatic and asymptomatic with more than 20 millimeters diameter. You can do exclusion bypass. That means above the aneurysm artery, you ligate. Below the aneurysm, you ligate the artery. Then you do a saphenous vein or inlay repair for the aneurysm. Femoral aneurysm, uncommon. Complications occur in less than 3% of the cases, and so conservative approach is done here. It may be associated with aortic aneurysm. Then iliac aneurysm, it occurs in conjunction with aortic aneurysm. Management, open inlay graft or endovascular aneurysm repair. There is a type of aneurysm called dissecting aneurysm. So this is an important topic. Now and then this is given as a short notes question in the theory examination. It is an aneurysmal dilatation due to dissection of the wall of the vessel. Dissection of the wall of the vessel. What does this mean? That means in atherosclerosis there will be thickening of the media and intima. Sometimes there may be a small break in the intima. Then blood passes into the arterial wall. The outer adventitious cord is strong. Media is degenerated. So in the layers of media, blood will circulate, causing separation of the inner layer of the media and intima from the adventitious cord. So this is called dissection, dissecting aneurysm. It occurs mainly in the aorta and its branches. Causes: atherosclerosis, trauma, iatrogenic like cardiac catheterization, intra-aortic balloon pumping, collagen disorders, hypertension, aortitis, previously due to syphilis. This is the aortic lumen. Here, at the ascending aortic arch, the plaque got separated. Then blood is leaking into the media, and blood spreads in the media like this. This is all the blood. So because of this, there will be dilatation of the aorta, and wherever it is passing, it causes constriction. All the branches of the aorta gets constricted by this blood in the vasomedia. Pathogenesis: rupture of atheromatous plaque leading to insinuation of blood between the inner and outer layers of media, causing aneurysmal dilatation. This can lead to rupture of aorta into the peritoneum or pleura, or obstruction of aorta or its branches. Type 1, dissection begins in the ascending aorta and extends to the thoracic aorta. Type 2, dissection begins in the ascending aorta and extends up to the branching of the major vessels. Type 3, dissection begins in the thoracic aorta after the left subclavian artery. Treatment: small segment resection and anastomosis, long segment creating an opening between the falls and true lumens. Arteriovenous fistula. Of course, before going to the arteriovenous fistula, Manogya has a doubt, I will clear it. Even after rupture of the abdominal aorta, will there be a pulsatile abdominal mass? Yes, there will be. Tell me how a pulsatile mass can occur after rupture of any artery. What do you call that? If a vessel is ruptured, It is hematoma and it is pulsates. It's called pulsatile hematoma. So even after rupture of the aorta, the blood leaks and forms a hematoma. The hematoma sits over the aorta and there will be pulsations. So this is the pulsatile hematoma. If it is delayed, then the hematoma gets organized, gets fibrosis, it gets the inner lumen which gets connected with the aorta, and there will be even expansile pulsations. Arteriovenous fistula. Normally this is the arteriole, here is the venule. Between these is the capillaries. So this is the arterial end of the capillary. Yes, if the complete rupture is there, it won't cause that hematoma, that pulsations. Yes, in every case of partial rupture, there will be a hematoma. In all closed injuries, there will be hematoma. If it is an open injury, there will be bleeding outside. Okay. So this is the normal capillary architecture. This is the arteriole. This is the arterial end of the capillaries. It also have the smooth muscle cover for it. Then these are the capillaries, and this is the venous side of the capillaries, and this is the venule. The pressure at the arterial end of the capillaries is around 40 millimeters of mercury. The pressure around in the venous end of the capillaries is 16 millimeters or 15 millimeters of mercury pressure. Why the pressure has dropped here? Because the blood has to flow through small, tenuous, long tubes, a long meshwork of fine tubes. That is why its pressure drops once it comes here. Then what is arteriovenous fistula? It is an abnormal communication between artery and vein, replacing or bypassing normal capillary circulation. So the normal capillary circulation is bypassed. You can see a vessel will occur here where it is being directly communicating the artery to the vein. So this is called the arteriovenous fistula. So there is no capillary circulation in between. Etiology: congenital and acquired. Acquired due to trauma, due to missile wounds or penetrating wounds. So whenever there is a missile or penetrating wound, the arteries and veins run together almost in many places. So if the injury to the artery and vein both take place, so there will be communication occurs between these two vessels, producing a direct arteriovenous fistula. Then iatrogenic for purpose of hemodialysis in renal failure. So surgeons or the urologist will create the arteriovenous fistula near the arm. Structural changes in arteriovenous fistula. When the artery and vein are get communicated, there will be aneurysmal dilatation of the artery and vein at the site of the fistula. So there will be a sac will develop which communicates with the artery and vein and that pulsates. So there will be an aneurysmal dilatation. The affected vein becomes dilated, thick-walled, and tortuous. This is called arterialization. Then varicose veins develop at the site of the fistula because more blood is being flowing into the veins. So the veins become arterialized as well as they become tortuous and elongated. Functional changes. We have seen here that the pressure at the arterial end of the capillary is 40, pressure at the venous end of the capillary is only 15. So there is a drop in pressure. And when you see the pressure in the inferior vena cava, it is only just 2 to 3 millimeters of mercury pressure, or 5 millimeters, less than 5 millimeters of mercury pressure. So this 15 millimeters of mercury pressure Once it goes to the inferior vena cava level, the pressure has dropped to only just 5 millimeters of mercury pressure. So because that pressure gradient is there, the blood is flowing towards the heart. Now when functional changes in arteriovenous fistula, when the artery is directly connected to the vein, so the blood is pumped directly from the artery into the vein directly. So the pressure at the artery is around 40 or 50 millimeters of mercury pressure. So the same 50 millimeters of mercury pressure will be there here. So when the pressure has almost become triple, then what will happen? The flow in the veins also will be more. So whenever the flow is more, the venous return to the heart also increases. So circulatory changes, there is decreased peripheral resistance and length of circulating vessels. This causes increased venous return and increased venous pressure. So pressure in the veins also will increase. That causes increased pulse rate and cardiac output. Because cardiac output is increased because of increased venous return, the pulse rate also increases. Diastolic pressure falls due to decreased peripheral resistance. So if there is a large arteriovenous fistula, the arterial resistance, so diastolic filling is reduced because it's being directly communicated to the veins. It need not go through the capillary network. So the pressure in the arteries drop during diastolic filling. So there will be increased pulse pressure. This is called the Corrigan's pulse. In long-standing cases, there may be cardiomegaly due to congestive cardiac failure. Extremities, increased venous tension can lead to edema and venous ulceration, and there will be increased local temperature. Because of the increased local temperature, the increased limb growth, especially if AV fistula is present before epiphyseal fusion. If this occurs before, that means in congenital AV fistulas, because of the increased warmth at the epiphyseal ends, there will be accelerated growth, producing the increased limb growth of the affected side. So you can see there is increased limb growth on this side. So features due to clinical features due to structural changes. Varicose veins in atypical position or age. Usually we find varicose veins of the long saphenous system or short saphenous system. But if you see varicose veins coursing over the lateral part of the thigh or lateral part of the leg or front of the thigh, then you must suspect some other thing, not the idiopathic varicose veins. There may be venous ulceration, local gigantism, pulsatile mass in the localized variety. This is called side aneurysm when it is superficial. Gangrene of the extremity if blood is shunted completely. Features due to functional changes, there will be thrill or continuous murmur with systolic accentuation. Pulse rate is rapid with increased pulse pressure. Branham's bradycardic sign. When the fistula is compressed, the pulse rate falls and diastolic pressure rises. So this is called as the Branham's bradycardic sign. So when you occlude the fistula, then venous return to the heart comes down to normal. Then the pulse rate falls. So this is called Branham's bradycardic sign. This is now and then given in the PG entrance examination. Heart, there will be cardiac enlargement and heart failure may be present. Cirrhoid aneurysm. Cirrhoid means varix-like. It is an AV fistula on the scalp. So if the AV fistula is there on the scalp. It is called the cirrhoid aneurysm. You can see these are the dilated veins. They become tortuous. That means they are almost varicose. And if you keep your hand over this, they will be pulsating. They are thickened. So they are not the actually arteries. They are only the veins which are directly communicating with the arteries. Because of direct communication with the arteries, they got arterialized. They become elongated, tortuous. So they are like varix. So any varix like pulsatile swelling on the scalp is called the cirrhoid aneurysm. So when you keep your hand over this mass, you will get the feeling of pulsating worms. The worms are there under your fingers or under your hand and they are pulsating. Now you can see this is an MR angiogram which is showing these dilated veins here. If there is port vein stain, that means discoloration of this is a capillary hemangioma of the skin. If there is capillary hemangioma associated with varicose veins, you must think of AV fistula. Investigations, arteriography to confirm the lesion, but it is difficult to identify the site of the lesion. Treatment for congenital AV fistula, conservative like elastic support, sclerogen therapy for varicose veins. Surgery difficult because it is extensive and associated with hemangiomatous tissue in the soft tissues and the bone. So not only the superficial structures, even the bone will be involved with these dilated arteries and veins. So surgery will be difficult. In the localized AV fistulas, excision and repair or therapeutic embolization can be done. For post-traumatic AV fistula, therapeutic embolization is ideal. Repair after excision of the fistula, or you can do quadruple ligation. That means if repair and fistula excision is not possible, the artery and vein connecting the fistula are ligated. So this is about the arterial diseases. Any doubts, please? If you have no more doubts, I will go to the case discussion on the disease of the breast. Yes, case discussion. Cases only. Okay. I hope you are talking about nipple discharge. So if there is serous discharge or if there is greenish discharge from multiple ducts, then it is physiological in the reproductive age. Physiological in the reproductive age. If it is not blood, if it is not pus, if it is not colloid material, it is physiological. Little amount of serous discharge or greenish discharge is physiological. It not occurs in every woman, but few women can have slight amount of discharge, not large amount of discharge. There will be only slight amount of discharge. Yes, it also can be physiological. That is why whenever there is nipple discharge, you must always check for two things. Number one, whether it has any blood by doing occult blood test. Number two, cytology examination for malignant cells. If these two are not there, then it is not pathological. It is not pathological. It can be of various colors. Usually it will be serous color discharge. Sometimes it will be slight greenish or slight yellowish in color, the discharge. Okay. Now we'll go to the topic of case discussion on the breast diseases. Clinical examination, already I told you. Just I will go fast through the slides. Presentation of breast disease. Patient usually come to you with the history of lump, nipple discharge, pain, or ulcer on the nipple areola complex. So how do you examine the patient? First, inspection, nipple examination, size. Is it flat, prominent, or retracted? Position, surface, discharge. Then areola, look for the surface, that means whether there is an eczema, ulcer, or nodule. Then skin over the breast for erythema, engorged veins on the affected side, pseudo-orange, dimpling, ulceration. Then see the breast is position, presence of dimpling and size. Surroundings like the arm, axilla, and supraclavicular fossa and the other breast has to be examined. Palpation, examine for lump, either from the skin, breast, retromammary tissues, or the chest wall, that is anatomical plane. By pinch and move test, feel. Feel means feel the lump. What for? Site, size, shape, surface, skin over the swelling, surroundings. Then consistency, margins, and fixity of the lump. So these characters of the lump you have to evaluate. Fixity already I told you. Infiltration of the corpus ligament, infiltration of lactiferous ducts, infiltration of pectoral muscles, serratus anterior, chest wall, skin. Then examine axillary and supraclavicular nodes. Then inquire about the bone pains. If any pain is there or swelling is there, examine the bones. Examine for hepatomegaly, ascites, and lung signs. So these are the, of course, already you have seen these things. So I have shown you about these axillary lymph nodes and the method of examination of axilla. The anterior, central, and apical nodes has to be palpated from the front. The posterior lymph nodes, subscapular, and the lateral group of lymph nodes has to be examined from the behind. Now, let's have discussion on this case. I hope all of you have read thoroughly. So you must be answering all the questions without any difficulty. Shall you continue with the charting, or do you want to go for oral answering so that we can finish off more number of cases? If you want to write down means it will take more time. Only chatting only? Okay. If you can engage yourself in mic, then we can have more discussions. More number of cases can be discussed. Okay. Whatever is convenient, you will go with this. Let us go with that. Case report. A female patient aged around 43 years complained of lump in the breast since 3 years. What the history you take? What history you take in this patient? Tell me. So that is about the lump. Then the lump is there in the breast. So you have to inquire some special features. You have to inquire some special features because the lump is there in the breast. You must inquire about the breast. Very good. Nipple discharge. Okay. History of lactation. So the history is mode of onset, progress, pain, swellings elsewhere, systemic symptoms. Inquire about discharge from the nipple. Then menstrual history and its relation to the swelling and the pain. History of lactation. Then symptoms regarding malignancy, like blood discharge from the nipple, bone pains, hemoptysis, abdominal distension, jaundice. It is a slow growing and painless mass. No other swellings. There is no discharge from the nipples. Elsewhere, swellings are not there. Menstrual history normal, not related to the breast swelling. She is not lactating. There are no symptoms of malignancy. Past history. You have to inquire about history of lumps, trauma, or surgery in the past on the breast. Personal history, smoking, alcohol. Then family history, similar swellings or history of cancer breast in the family. So she had no past history of any lumps or trauma or previous surgery. Personal history, it is not relevant. Family history, no, it is not specific about any positive things here. Examination. General examination, anemia, clubbing, jaundice, pyrexia, loss of weight. Then local examination, inspection, the nipple. It is not not retracted, but deviated to the left. Areola. A small nodule is present at 8 o'clock position. You can see here, this is at 8 o'clock position. This is nothing but a Montgomery tubercle. Skin, no abnormal detected. That means no engorged veins, no erythema, no shininess. Breast, large globular mass is seen in the outer and upper quadrant. Surroundings, axilla, supraclavicular fossa, and other breast are normal. You can see on elevation of the limbs also, the breast is not pulled upwards. Only the mass is becoming more prominently seen. Palpation, examine for the lump by pinch, move, and feel test. So these are the three tests you do for the lump examination. Pinch. Pinch the skin over the swelling. Move. Move it over the contracted pectoralis major muscle as well as move it over the relaxed pectoralis major muscle. So by this you can say from the skin, breast, retromammary tissues or from the chest wall. That means anatomical plane can be evaluated by these two tests, pinch and move test. So you can see here the mass is, I'm able to move the mass in the horizontal direction. Then I am able to move the mass in the vertical direction. You can see the patient has kept her hand over her hip and tightly pressing it. You can see the prominent pectoralis major, that means anterior pectoral fold is seen prominently here. So you try the movement in the horizontal axis as well as in the vertical axis. So the mass is mobile in both directions on contraction of the pectoralis major muscle. So what does it mean? What is your inference? Not fixed means not fixed to what? Yes, it is not fixed to the pectoral muscle. It is superficial to the pectoralis major muscle because it is more prominent. It became more prominent and it is mobile. So that means it is in the breast tissue and it has not infiltrated the pectoralis major muscle. You can see the mass has become more prominent. Skin is pinchable all over the swelling, mobile over the relaxed and contracted pectoralis major muscle, and becomes prominent on contraction of pectoralis major muscle. So that means skin is not adherent or not infiltrated, not fixed to the pectoral muscle, and became more prominent means it is situated superficial to the pectoralis major muscle. Don't say above the pectoralis major muscle. You call it as superficial or deep. Don't say above or below. So call it as superficial. Yes. Then feel there is pathological diagnosis. So in the palpation, you have to do three steps. One is the pinch test, the other is the move test, the third is the feel test. Pinch, move, and feel. So these are the three tests you have to do for a swelling examination. So feel. What for you feel? For the pathological nature. What are the things you examine? Site, size, shape, surface, skin over the swelling, surroundings, edges, warmth, tenderness, consistency, margins, fixity. So these characters you have to see for any swelling anywhere in the body when you're examining. So you can remember 5S or 6S: site, size, shape, surface, skin or the swelling and surroundings. Plus local warmth, tenderness, consistency, margins, fixity. There are again another 5. So total these 11 points you have to examine for the pathological diagnosis. So in this patient, is upper and outer quadrant of the right breast. Size is 15 to 12 centimeters. Shape is globular. Surface is bossulated. Bossulation means it is not smooth. It is rather uneven. Skin over the swelling is stretched. Surroundings healthy. There is no warmth, not tender. Consistency firm. Margins well defined. Fixity, not fixed to the skin, breast tissue, corpus ligaments, and pectoral. So these are the pathological features. So please look at these pathological features. Okay. Now I'll go to the next slide. Axillary and supraclavicular nodes are not palpable. Abdominal examination, liver, ascites, other mass, liver not palpable, ascites not present, no other mass in the abdomen. So summary. So this is the right breast. Why? Because this is the Spencer style. It is going towards the lateral side. So it will be there on the upper and lateral quadrant. So this is from the right breast. This is the axilla. So this is the mass. So what is the nature of the mass? A female patient aged around 40 years has the mass for the past 3 years. The mass for the past 3 years. It is slowly growing in size and attain this size. It is 12 to 15 centimeters in size, mobile, non-tender, not fixed to any of the surrounding structures or to the muscle, no axillary nodes, no visceral metastasis. So what is your clinical diagnosis here? A lump in the breast, first of all. The lump can be traumatic, inflammatory, benign neoplasm, malignant neoplasm. So is there any history of trauma? There is no history of trauma. Is it an inflammatory swelling? That means, are there any signs of inflammation? Are there any inflammation of signs here in this case? Either symptoms or signs denoting inflammation? No. That means it is not an inflammatory swelling. Then can it be a benign swelling? Can it be a benign neoplasm? Consistency is firm. That means there is no induration. Borders are well defined. There is no evidence of any infiltration. There is no involvement of lymph nodes or distant organs. The three eyes of a malignancy are not seen in this case. So this appears like a benign neoplasm. So what are the benign swellings in the breast? What are the benign swellings in the breast? Okay, you forgot about the Filler's tumor. Santi, why do you say it is not a cyst? Why? Why is it not a cyst? Cysts have only very regular, definite margins. Cyst will be globular. It is globular. Clinically, we say it is not a cyst because it is not soft in consistency. It is not soft in consistency. But even though it is not soft, still it can be a cyst because a tense cyst may have firm feeling. A tense cyst will have firm feeling. Okay. So what is the clinical diagnosis? Anatomical diagnosis. What is the anatomical diagnosis here? The swelling is arising from the breast parenchyma because it is superficial to the pectoralis major muscle. Then what is the pathological diagnosis? Large benign lesion. That is the pathological diagnosis. What are large benign masses in the breast? Giant fibroadenoma. What is giant fibroadenoma? What is giant fibroadenoma? Yes, when the size of the fibroadenoma is more than 5 centimeters, it is called giant fibroadenoma. It is only more than 5 centimeters is called giant fibroadenoma. Then other benign tumor which is large in size is the Filler's tumor, a cyst, and sometimes medullary carcinoma can also manifest like that in the early stages. So these are the differential diagnosis for this case. What are the points in favor of benign swelling? History. That means 3 years is a long history. That means it will be only benign swelling. Malignancy means it will be in periods of duration of only months. Examination findings: this mobile, well-defined mass without features of infiltration and swelling of axillary nodes or metastasis. What are the points in favor of malignancy? Large size, breast mass in patient aged about 43 years. Because at 43 years, fibroadenoma is very, very, very uncommon. And because of size, you have to think of they're in favor of malignancy. Okay. How do you manage this case? So your clinical diagnosis is a large benign tumor. This can be Filler's tumor, giant fibroadenoma, or a cyst. Now, how do you manage? Any breast lump, the first thing you must say is the triple assessment. You are right. Triple assessment. Clinical examination. What is triple assessment? What is triple assessment? Is clinical examination, imaging studies, and cytological or histological examination. Imaging is by mammography to see for the nature of the lesion, calcifications and other masses. Ultrasound scan, solid cystic mass, axillary node sprains. MRI scan, of course, is not required in this case. Cytological and histopathological examination by FNAC, core biopsy. If FNAC reveals fluid and aspiration, what is our next line of management? Aspiration, okay. Then what you do? Okay, aspirate it. Okay, then you have aspirated till the last drop. Then what you do? Send it for cytology. Okay, next, what else you do? When do you operate on the cyst? What are the indications for surgery of a cyst in the breast? When will you operate? Whenever there is a very good solid remnant, blood stained fluid, not resolving even after or recurring after even after 4 aspirations, presence of blood, wonderful. So these are the indications for the excision. Okay, if you take core biopsy, then you must study for the histology. So the fibroadenoma histology and Phyllo's tumor histology, you should know. Just I will give briefly about fibroadenoma. There will be overgrowth of fibrous and glandular tissue. Intralobular stroma encloses glandular spaces. Pericanalicular. There are two types of fibroadenoma, intracanalicular and pericanalicular. Phyllo's tumor cannot be differentiated from fibroadenoma on pathological examination. In general, benign Phyllo's tumors demonstrate a markedly increased number of regular fusiform fibroblasts. Occasionally, highly anaplastic cells with mixed site changes may be observed. A high degree of cellular atypia with increased stromal cellularity and increased mitotic count is almost always observed in malignant Phyllo's tumor. About this case, ultrasound scan was done. A well-defined hypoechoic mass with necrosis here and there, no calcification. So it is a hypoechoic mass. So there is no anechoic region. That means it is not a cyst. FNAC, few fibroblasts and ductal cells seen. Core needle biopsy, report came as the Phyllo's tumor. Now, how do you treat this case? So ultrasound scan was done, clinical examination done. It is a benign tumor, clinically. FNAC was done, only some ducts and glands are seen. Core biopsy report came as Phyllo's tumor. Ultrasound scan showed a uniform hypoechoic mass. Now, how do you treat this case? That is what the treatment for Phyllo's tumor. ultrasound scan of the abdomen, X-ray chest is taken to evaluate for any secondaries. Options in surgical management of Phyllodes tumor. These are the options: enucleation, excision, wide excision, mastectomy, and modified radical mastectomy. Modified radical mastectomy is abbreviated as MRM. Enucleation, not advocated in Phyllodes tumor. Simple excision should not be done. What is the difference between enucleation and excision? What is the difference between enucleation and excision? Are they same or different? Okay, inside the capsule and remove the tumor inside the capsule. That is what intracapsular excision is called the enucleation. If you remove the mass along with its capsule, it is called as the excision. Okay, wide excision, 2 centimeters margin for small tumors and 5 centimeters margin for large tumors. Mastectomy is advocated if the tumor breast ratio is large. That means if the tumor is very large or recurrent, mastectomy is done. Modified radical mastectomy, that is simple mastectomy with axillary clearance, is not indicated. So there are two options for Phyllodes tumor. If the tumor is in small size, you can do a wide excision. If the tumor is large size, you have to go for a simple mastectomy operation. So already we discussed about Phyllodes tumor, so I will skip this slide. So in this case, what do you do? In this case, you have to go for simple mastectomy because the mass is a large size. Almost more than 50% of the breast is occupied in the breast. So you have to remove the mass along with the breast. That is simple mastectomy. Yes, Santhi, you can speak now.
Yes, sir. Sir, can you hear me, sir?
Santhi, you can speak.
You can't hear me. Sir. Hello?
I can hear you.
Okay. Sir, actually, Phyllodes tumor, the size, in this, the size is very large, no, sir. So, like,
Yes.
why can't we give radiotherapy for local recurrence here?
Local radiotherapy?
Yes, sir. I mean, for local recurrence.
No, it is not recurred. It is not recurrent tumor.
Okay. Means, Phyllodes tumor, you said,
There
like,
is no effective support.
it's a
Yes,
pre-malignant
tell me.
condition.
No, it is not a pre-malignant condition.
Okay, if only histology shows any cytological changes, then only we'll do radiotherapy, sir.
The indications for the mastectomy being number one, large size. Number two, if there are any increased mitotic figures, because this is an intermediary malignant tumor. Sometimes it can undergo sarcomatous transformation. That means malignant transformation. All Phyllodes tumors do not become sarcomas. Some Phyllodes tumors can show malignant transformation. How do you know that? On histology. When you do the core biopsy shows the presence of pleomorphism in these cells, then we will suspect it to be malignant. So in that condition, and when a large mass is there, then you have to go for simple mastectomy. Radiotherapy comes only into picture if it is malignant. If it is simple benign Fillers tumor, there is no role for radiotherapy treatment. Okay. If FNAC shows, sorry, if axillary nodes are present, then you have to do FNAC. If they are positive, you have to go for axillary dissection. Okay, we'll go to the next case. I hope you have read the case notes here. Female age 54 years, complaint of breast lump since 2 years. This is the history you have to take. Mode of onset, progress about the swelling, discharge from the nipple, menstrual history, lactation, malignancy symptoms. It is a slow growing painless mass. There is no discharge from the nipple. Menstrual history, she is 54, she is postmenopausal. History of lactation, not there. Malignant symptoms of malignancy like blood discharge, bone pain, hemoptysis, abdominal distension, jaundice, they are not present. So examination, you look for the plane of the swelling, whether it's from skin, subcutaneous tissues, from the muscle, or retromammary tissues. Then pathology, you examine for the nipples, their levels, retraction, discharge, then areola, and about the mass. Then you test for the skin pinchability test. Then you test for the mobility of the mass over the pectoralis major muscle. Mass is in the left breast, outer and upper quadrant, measuring 5 by 4 centimeters. Irregular. Skin over the swelling is normal. Non-tender, no warmth, hard in consistency, well-defined, irregular borders, not mobile in the breast tissue. Skin and pectoralis major muscle are not fixed to the mass. They are free. So go through the examination findings carefully. Once again. Okay. Axillum, 3 nodes are palpable in the anterior group. Other breast and axilla are normal. Supraclavicular nodes not palpable. Abdomen is normal. Lungs and bones, no abnormality detected. What's your diagnosis? Why do you say carcinoma? Why do you say it is carcinoma? What are the points in favor of carcinoma? Actually, whenever nodes are palpable, you have to describe about the nodes also. How many are involved? What is the size of the nodes? Whether the nodes are hard, firm, or soft in consistency, whether nodes are fixed to one another or not, and whether the nodes are fixed to the surrounding structures. So these points you must tell whenever you feel the lymph nodes. Here the lymph nodes are hard in consistency, they are discrete, not fixed to the surrounding structures, and they are not tender. So here it is a hard swelling, irregular surface, well-defined margins, a postmenopausal woman, fixed to the breast tissue with axillary node presence. That is why you will suspect carcinoma of the breast in this case. You must specify which side, carcinoma of the left or right breast you must mention. Though patient has said in the symptoms lump in the left breast, but in the final diagnosis you must mention which side. So you must mention it as carcinoma of breast left. Number one. Number two, you must tell the stage also. TNM stage. So tell me this TNM stage here. What is the TNM stage here? Why do you say it is N3? Santi, why do you say it is N3? Okay, it is N2. It is 5 centimeters, means it is a borderline between the T3 and T2. So it is a borderline tumor between T3 and T2. So you can say either T3 or T2 because 2 to 5 centimeters is T2, more than 5 centimeters is T3. So you can say T2 is more appropriate in this case. So it is only N1, it is not N2. Mobile lymph nodes in the axilla is N1. Fixed lymph nodes in the axilla is N2. Presence of supraclavicular nodes is N3. What investigations you do for this case? What are the investigations you do for this case? Very good. You do mammography, FNSA, and core biopsy. The core biopsy report came as duct cell carcinoma. So the pathology is diagnosed. Then, what other investigations you do now? So you have done FNSA, mammogram. They have shown, mammography has shown a hypoechoic mass. FNSA has shown pleomorphic cells. True cut biopsy has shown duct cell carcinoma. So what other investigations you do? Is look for secondaries, means chest X-ray, LFT, ultrasound scan of the abdomen. Very good. Sentinel node biopsy is not done now. Sentinel node biopsy is not an investigation, it is a part of treatment. During surgical procedure, you do the sentinel node biopsy, not now. So staging is investigated by X-ray chest, ultrasound scan abdomen. There is no abnormality. Then bone scan, your bone pains are present. PET scan for occult secondaries. It is not done in this case. Now, how do you manage? Core biopsy report is duct cell carcinoma. She is having axillary lymph nodes. It is 5 centimeters lesion. So, how do you manage this case? What treatment do you offer to this patient? First of all, is it a low risk case or high risk case? Why do you say it is high risk? Why do you say it is high risk case? Yes, very good. Axillary node positive, that is high risk case. Is not in favor of high risk. Actually, less than 35 years is high risk, not 54 years. Of course, size more than 5 centimeters is high risk. Okay. Histology, of course, I just mentioned duct cell carcinoma. I didn't tell about the grade. If the grade is 3, that means ill-differentiated tumor, it is high risk. But whatever it is, because there are axillary nodes, it is a high risk case. So now tell me, how do you manage this case? Okay, what you should do here is, what you have to do here is, it is a T3 lesion around 5 or less than more than 5 centimeters. So you get it to a lesser size by giving neoadjuvant chemotherapy or radiotherapy followed by surgery. Surgery, you have two options. One thing is, you can go for breast conservation surgery once the size is reduced, followed by radiotherapy to the breast and axillary node dissection. That is one option. I repeat, wide excision followed by radiotherapy and followed by axillary node dissection. So this is the procedure, one option. Second option is, go ahead and do straightforward modified radical mastectomy. Patient is 54-year-old. She doesn't bother losing one breast. She wants a recurrent free, long survival course after treatment. So when the two things are explained to her, patient opted for the mastectomy operation. So neoadjuvant chemotherapy, after 3 weeks it became T2, then modified radical mastectomy done. Because patient is having axillary node positivity, she should have systemic therapy later. 5 nodes are positive for malignancy. So once you do MRM, that is modified radical mastectomy, you have to submit this whole specimen for biopsy. The biopsy report says that 5 nodes are positive for malignancy. That means it is a high risk category. High risk category means they need systemic adjuvant treatment. And they are ER positive. So patient was given adjuvant hormone therapy as well as chemotherapy. What hormone therapy you give usually? What hormone therapy you give for ER positive cases? What is other drug? What is other drug? Okay, you can give LHRH. Okay. What is ALD? I could not get it. Okay. ALD means aromatase inhibitors or something else. Yes, you are right. It is LHRH and aromatase inhibitors. So you can give those hormone therapy. Okay. So I am going to discuss about third case. A female age 38 years complained of lump in the breast since 2 years. The history, anyway, I already told you. You would inquire about the swelling, then discharge from the nipple, menstrual history of lactation, malignancy symptoms. It is slow growing painless mass, no other swellings, discharge from nipple is not there, menstrual history normal and there is no relation to the menses, no history of lactation, no malignancy symptoms. What do you examine? Plane of the swelling. Skin is pinchable. Swelling became more prominent on contraction of pectoralis major muscle. These are the findings. Hard, irregular, non-tender lump fixed to the breast tissue and not to the pectoral fascia or skin. It is also measured 5 centimeters in diameter. Nipple retracted and deviated to the left, laterally and downwards. Axilla showed 3 discrete hard mobile nodes in central group. You can see the axillary nodes here, which are enlarged. Other breast and axilla are normal. Abdomen normal, chest and bones are normal. So whenever you examine, you must tell all these findings. What is the diagnosis? Yes, it is carcinoma of the left breast. T2N1M0. So the investigations are same thing: FNAC true cut biopsy, X-ray chest, ultrasound scan of the abdomen. Histopathology report is invasive duct cell carcinoma. Chest and abdomen, no secondaries. How do you manage? Similar lines. Pattis mastectomy, because axillary nodes are positive. Adjuvant hormone therapy, adjuvant chemotherapy. If HER2 receptors are also positive, you have to go for monoclonal antibodies like Herceptin, docetaxel, or paclitaxel. if HER2 receptors are positive. What is HER? What is HER? HER. Very good. Okay, this is already I told you. Okay, next case. A female aged 43 years complained of lump in the breast since 3 years. History, same thing about the lump, discharge from nipple, menstrual history, lactation history, malignancy symptoms. Slow growing, painless, no other swelling, discharge from nipple is not there, systemic symptoms not present, not related to menses, no history of lactation, malignant symptoms are not present. Check for the plane of the swelling, skin, breast tissue, pectoral muscle, subpectoral fascia, rib case. Test for skin pinchability and movement with the skin. Unexamined skin is mobile, swelling is mobile, and moves over contracted and uncontracted pectoral muscle. What is the plane of the swelling? Yes, it is the mass arising from the breast. What is pathological diagnosis? Test for success, consistency, margins, level of nipples, and for retraction. Examine axilla, other breasts, and supraoculars. Examine abdomen for hepatomegaly, pelvic mass, and ascites. Mass is 7 to 8 centimeters. Form bosulated, well-defined margins, mobile, non-tender, form swelling with normal nipple levels and areola. The other axilla, the axilla are normal. So it is a large benign swelling. It can be due to giant fibroadenoma, Phyllo's tumor, cyst, just like in the previous case. Of course, carcinoma breast must always be there in your differential diagnosis. Though it has benign features, you must say it may be a carcinoma. Investigations, same triple assessment. Ultrasound scan showed a solid mass. FNAC, benign ductal cells confirmed by true gut biopsy. So benign tumor, probably Phyllo's tumor. That is the benign tumor. Then true gut biopsy. So how do you manage? Now how do you manage? I told you already. For small tumors, go for wide excision. For large tumors, where mass versus breast ratio is narrow, you have to go for simple mastectomy. For in this case, you have to go for wide excision. A fibroadenoma is not common in this case, and the tumor is large, Phyllo's tumor is diagnosed, and wide excision is done because of its locally malignant nature. Swelling breasts, 5 years, slow growing and painless. This is the swelling. And of course, there are 2 nodules here. But patient came for this swelling. So again, the same history: swelling, menstrual lactation, malignancy. Check for the plane of the swelling: skin, breast, pectoral muscle, or subpectoral area. Then you do pinch, move, and feel test. So these are the things you have to do in the examination. You will see skin pinchability is being done. Skin not pinchable, and swelling moves with the skin. What is the anatomical plane? You will say infiltration if a mass is there under the skin and skin is not pinchable, then you say infiltration. If there is no mass under the skin but the mass is in the skin, how can you say? Because the mass moves with the skin. If you move this mass, the skin moves. If you move the skin, the mass moves. That means it is there in the skin. So then you should not say infiltration. You should say only mass arising from the skin. So it is skin swelling. So what is the pathological diagnosis? Skin swelling, skin over the breast swelling. What is the pathological diagnosis? You do the examination, palpation, 6S: site, size, shape, surface, skin over the swelling and surroundings, consistency, mobility, and margins. So first of all, tell me, what are the swellings arising from the skin? So these are the swellings that arises from the skin. They can be classified into solid and soft swellings. Solid swellings, feel for the pathological nature and look for the signs: inflammatory signs, benign signs, malignant signs. So soft swelling is a sebaceous cyst, abscess in the skin, hemangioma, or lymphangioma. So these are the four things that can be there in the skin soft swelling. Feel for the pathological nature. So inflammatory, benign, malignant. Inflammatory swellings: boil, carbuncle, condyloma. Benign: a wart, neurofibroma, mole, and cylindroma. Malignant: rodent ulcer, epithelioma, melanoma, dermatofibrosarcoma, protuberance. So these are the causes of skin swellings. The swelling is soft, not tender. So what is your diagnosis? So there are no signs of inflammation. The skin is soft in consistency. Swelling is soft in consistency. So what is your diagnosis? Yes, it is sebaceous cyst of the skin over the areolar region. What do you find? There are two other nodules, one at 11 o'clock and other at 1 o'clock. What are they? They are the Montgomery tubercles. No, it is not duct ectasia, it is Montgomery tubercles. Duct ectasia will not manifest like that. Duct ectasia will be subcutaneous swelling. Subcutaneous soft swelling if it is an abscess, where skin can be pinched over it. But here you can't pinch this skin over this swelling. That is why you say it is a skin swelling. Because it is soft skin swelling, you say it is a sebaceous cyst. Okay, with this I will stop here. Any doubts? Yes, they can persist even after lactation also. Are there any more doubts for you? Okay, next class, what do you want? No, they can persist even after lactation also. Okay, do you want any next class or not? Number one. If you want next class, what class do you want? It is Montgomery tubercles only. This is the Montgomery tubercle. They will reduce in size after lactation and they persist like that because they are the sebaceous glands which have become hyperplastic. So sometimes the hyperplasia will not come down, they persist like that. Okay, what topics you want? Shock. The topics on vascular diseases being next is the disease of the veins and disease of the lymphatics. These two are the simple topics where you can read through the book. That's what I felt. But if you want me to take, I will take those topics also. Ajay, do you want veins also? Veins and lymphatics also? What about others? Monognia wants to have topic on the disease of the veins and later on lymphatics. What about others? Do they want that or any other topic? Okay. Okay, I will go ahead with the topic on. Okay, if you want to have both these things, so next class we will have on the veins. The lymphatics, of course, is a very simple topic, so you can read it, no problem. Then we will go to the shock. So we will have the discussion on the veins and the shock. Okay. So I will give the schedule by tomorrow morning or tomorrow afternoon. You can go through that and then you can join the classes. Any more doubts, please? If you have no more doubts, I will close this session. Thank you very much. See you tomorrow. Tomorrow at 4 p.m. So we will have the class at tomorrow at 4 p.m.